There are occasions when the nurse may be called upon to suture deep and large lacerations which cannot be drawn together with simple butterfly strips so that the skin edges will heal rapidly with minimal scar formation. Individuals who have been properly instructed and certified according to their administrative SOP may do minor suturing. Today you will observe the proper technique utilizing the interrupted stitch. Lacerations to be sutured must not be more than 12 hours old, grossly contaminated, or deeper than the subcutaneous tissue. For the actual procedure itself, gather the equipment necessary for suturing, including a suture set, suture, lidocaine, 18 and 25 gauge needles, sterile gloves, a surgical cap, and a mask. Preparing the patient for suturing is part of the nurse's responsibility. The patient should be made as comfortable as possible. The patient or guardian must sign a consent form. The physician first inspects the wound in the emergency room in preparation for suturing. Individuals other than the physician cannot suture the face, palms of the hand, or soles of the feet. According to the physician's orders, have the patient soak the wound in an antiseptic solution for 10 minutes. A suitable solution is betadine and water. Dry off the wound with sterile 4x4s and re-inspect it for cleanliness. If it still contains debris, scrub and irrigate the wound. It is imperative to remove all debris from the wound in order to prevent infection and an overgrowth of scar tissue. Before opening the outer wrapping of the suture set, check the sterilization strip and expiration date on the outside of the suture pack. Also check the sterilization strip inside the outer wrapper. Don the surgical cap, mask, and sterile gloves for the procedure. A sterile gown may also be worn. Then open the inner pack while maintaining a sterile field. Inspect the contents of the pack. It should contain a drape, towels, 4x4s, 1-point sharps, needle holders, tissue forceps, and syringe. Before beginning to suture, the wound must be anesthetized. Explain to the patient that he will feel the insertion of the needle and the anesthetic agent. Shortly thereafter, a numbing sensation should be felt by the patient. Even local anesthesia can cause severe allergic reactions, so it is vital to check the patient's history for any allergies. Have resuscitative drugs and equipment available. Lidocaine is the most widely used local anesthetic. Remember these guidelines when using lidocaine. The recommended concentration is 1% for infiltration. The time of onset is 3 to 10 minutes. The effects last approximately 3 hours, and the maximum dosage is 300 milligrams or 7 milligrams per kilogram of body weight. An 18-gauge needle is used for drawing up lidocaine. A 25 to 30 gauge 1-inch needle is used for the actual injection. The amount usually does not exceed 5 cc's, so the 5 cc syringe included in most suture sets will be adequate. Lidocaine with epinephrine, a vasoconstrictor, may be ordered by the physician in order to decrease the rate of absorption, lessen toxicity, prolong the expected duration of the drug by approximately 50%, or decrease the amount of bleeding from the site. Epinephrine must not be used to suture the appendages where it could cause gangrene, or for patients with hypertension, cardiac, or peripheral vascular disease. Before anesthetizing the wound, drape the area. Inject lidocaine into the tissue at the wound edges. Wait 3 to 10 minutes, then test for numbness with a sterile needle. When it is certain that the area is anesthetized, the actual suturing procedure can begin. Select the proper type and size of suture. Suture for external wounds is either silk or nylon. The suture sizes range from 2/0, which is coarse, to 6/0, which is fine. For cosmetic areas, the finer suture is preferred. Attach the suture needle to the needle holder and place it in the dominant hand. Hold the tissue forceps in the other hand. Begin suturing in the middle of the laceration so that the edges will be evenly matched. Beginning this way also prevents puckering. Puncture the uppermost layer of the skin 1/8 of an inch from the incision edge. Use the forceps to separate the layers of skin so the needle tip will be exposed. You need to visualize the needle tip to prevent it from entering the dermis. Using the curvature of the needle, aim the needle upwards from the bottom of the opposite skin edge and puncture the uppermost skin surface, also 1/8 of an inch away from the edge. Continue to use the forceps to separate the skin layers. Release the needle holder and grasp the needle near the point with the holder. Draw the suture through both sides of the incision until 2 centimeters of the free end remain, and release the needle holder. Hold the end of the suture that has the swag needle in the non-tying hand. Wrap the suture around the needle holder 3 times in a clockwise direction. Grasp the free end of the suture in the needle holder. The needle holder always grasps the free short end for tying. Pull the free end through the 3 loops and tighten to form the first knot, pulling the short end in the same direction where it lay after pulling it through the loops on the needle holder. The free hand pulls the needle end of the suture in the opposite direction. The finished stitch should slightly pucker the skin so that after edema subsides and the skin is slightly stretched, the stitch will hold the skin firmly but without puckers. Do not tie the knot directly over the wound. Wrap the long end of the suture twice around the needle holder in a counterclockwise direction. Pull the short end through the loops and pull ends to tighten the knot and complete the second knot. Wrap the long end of the suture once around the needle holder in a clockwise direction. Pull the short end through the loop and pull ends to complete the last knot. Remember, always pull the needle end in the opposite direction of the side where the short end of the suture emerges from the skin. The short end is pulled in the opposite direction. Finally, cut off the suture close to the knot. The first suture is now complete. Continue with subsequent sutures on either side of this first suture, spacing them 1/8 of an inch apart. After suturing the patient's wound, follow-up nursing intervention includes teaching the patient how to care for the wound. Follow the SOP of your clinic in providing patient education. In many instances, the patient is told not to get the sutures wet. The patient should also be told when to return to the clinic for suture removal. This is usually done in several days. As in all forms of nursing care, prompt and accurate documentation is essential. Be sure to note and record the antiseptic solution used for soaking the wound, the doctor's name, the anesthesia used, the type of suture used, the number of sutures applied, patient teaching given, and the date the patient is to return to the clinic for follow-up. Knowing the correct technique in applying sutures can greatly assist any healthcare team. It is also essential to be able to perform this technique in such a manner that it will not cause any infection or leave any permanent disfiguring scar.